Good afternoon and welcome to today's program entitled Treatment Innovation in Hemophilia A, Integrating Extended Half-Life Replacement Clotting Factors into Clinical Practice. My name is Mark Redding. I am the Director of the Center for Bleeding and Clotting Disorders at the University of Minnesota Medical Center here in Minneapolis. I want to extend a thanks today to Medical Learning Institute and to Peerview Institute for Medical Education for their work in developing this educational event. Thanks also to Bayer Healthcare Pharmaceuticals for providing an educational grant for today's symposium. Okay, let's get started with the program today. So as I'm sure as you all are very well aware, hemophilia A is an X-linked inherited bleeding disorder characterized by deficiency of coagulation factor VIII. The incidence of hemophilia A in the general population is 1 out of every 5,000 male births, and there is no specific racial or ethnic predisposition for this condition. There are approximately 20 to 22,000 severe hemophilia patients in the United States, with about 80% of those individuals having hemophilia A and the rest hemophilia B. The focus of today's program is hemophilia A. Without proper treatment, bleeding events in those with hemophilia may be life-threatening, and they certainly can result in chronic disability from recurrent joint bleeds or hemarthroses. The treatment of hemophilia has evolved tremendously over the last several decades. Beginning in the early part of the 1900s, we were first able to transfuse whole blood. The problem there, though, is there's very little factor concentrated in 1 unit of whole blood. Plasma and cryoprecipitate contain more factor, but still in amounts that are not high enough to effectively prevent and treat bleeding episodes. It wasn't until the 1950s and 1960s and on into the 70s and 80s where we developed the ability to fractionate blood and to pull out from the plasma the part of the components that actually contain factor VIII and factor IX. And so those plasma-derived concentrates became available and were a significant advance forward in our ability to manage hemophilia. However, the modern era of hemophilia management really didn't start until the 1990s with the advent of the recombinant clotting factor concentrates. This was a major advance in our treatment ability, but for about 30 years, nothing really changed. We had recombinant factor products, we had safe plasma-derived products, but there really wasn't anything new until about 2010 when we started to see the publications of studies describing the use of extended half-life factor concentrates. The first of these drugs was approved in 2014, and since that time, over the last 4 to 5 years, we've seen a rapid expansion in our therapeutic armamentarium. We now have several extended half-life products available, and we're also at the very beginning of what we think will be a new era of treatment with non-factor replacement therapy. The focus of today's program will be on the extended half-life factor VIII products. So there are 2 basic ways to treat hemophilia. We can treat episodically, which means we give factor when a bleeding event occurs. This is quite effective at stopping bleeds, but it really doesn't do anything to prevent bleeds, which is crucial if we're going to prevent the devastating joint disease that unfortunately will happen if bleeds occur. Prophylaxis then is the standard of therapy for hemophilia. Prophylaxis means we give clotting factor concentrates on a regular schedule with the intent of preventing bleeds from occurring. Continuous prophylaxis can be broken down into primary, secondary, and tertiary depending on the age and the joint status at which it is begun. Intermittent prophylaxis is also used by a number of our patients, and the only difference here is that it's not continued ongoing without fail. So intermittent prophylaxis, for example, may be used for a period of time following a major surgery or following a bleeding event to get things to quiet down. The ideal way of doing prophylaxis is to do it continuously and to start at a young age. So primary prophylaxis is really our goal for all patients now with hemophilia. The benefits of prophylaxis are very clear. There are a number of studies that have looked at this. We don't have time to go into all of the details of that, but here are a couple of examples. Probably the study that we're all the most familiar with is the landmark joint outcome study. This was published by Marilyn Manco-Johnson and colleagues now almost 10 years ago, actually almost 12 years ago. This study showed without question that the early use of prophylaxis in young boys with hemophilia not only significantly prevents joint bleeds, but also significantly increases the chance of having radiographically normal joints after a several-year period of treatment. Following the joint outcome study, a number of other studies have also reaffirmed these results, including data from the Esprit trial, which supports the use of prophylaxis over episodic therapy in patients with hemophilia A. So prophylaxis is the standard of care for patients with hemophilia. However, this is a very difficult treatment for patients to adhere to long term. The frequency of infusions needed to maintain factor levels at a protective amount is quite a burden for our patients. Standard factor replacement therapy presents a major challenge because the half-life of standard factor VIII products is about 8 to 12 hours. This translates into a need to infuse the product about every 2 to 3 days in order to maintain factor levels in a protective range. With this in mind, then, the extended half-life products were developed. The goal of these products is to do something to the factor VIII protein to extend its half-life, with the goal of either supporting higher trough levels at the same infusion interval or the ability to extend the infusion interval to longer periods of time to decrease the number of total infusions required over the course of a month or a year and yet still maintain protective factor levels. Thus far, 2 successful approaches have been established in hemophilia A: FC fusion and PEGylation. We'll talk about each of these in some detail, and then we'll go into some of the different drugs that have used these strategies to extend the half-life of factor VIII and are available now for our clinical practice. Okay, moving on now into the current clinical evidence regarding the use of extended half-life factor VIII products in hemophilia A. As I mentioned just a bit ago, there are 2 main mechanisms that have been used to prolong the half-life of factor VIII. One is FC fusion, and the other is PEGylation. This slide shows an example of what FC fusion is. FC is a portion of the human IgG antibody protein which can be attached to proteins with the intent of extending their half-life in the circulation. IgG proteins have a half-life of approximately 3 weeks in circulation, and so the idea here is that if we attach the FC end of an antibody protein to something like factor VIII, that long half-life of the natural antibody could be then transferred to the protein of interest, in this case factor VIII. The other method that's been used to extend factor VIII's half-life is PEGylation. This involves the attachment of a polyethylene glycol protein, or molecule rather, to the protein itself, which again extends the half-life. This works through a different mechanism than FC fusion. PEG molecules are quite large, and this large size then inhibits the ability of these proteins attached to PEG to be cleared by the kidney. Attachment of PEG also interferes with binding of the protein to clearance receptors in the liver. If we attach PEG in very specific places, we can obtain these beneficial effects without interfering with the normal procoagulant function of factor VIII. The PEG molecule is then cleaved upon activation of the factor so it functions normally in the coagulation cascade. The overall result then is a factor VIII protein which is fully functional and has an extended half-life. This is another cartoon that explains a bit more about what happens with PEGylation. The PEG is again a very big molecule. When it's attached to the protein, the overall size of the drug is increased. This not only improves its water solubility, but also again impairs its ability to be cleared through the kidney and the liver. Okay, so let's talk about extended half-life factor VIII products that are currently available, and I'll also mention briefly a couple that are soon to be available probably in the near future. So the approved extended half-life factor VIII products include F-moroctocog alpha, which is an FC fusion protein, and then we have 2 PEGylated proteins that are now available. We have rureoctocog alpha PEGol and democtocog alpha PEGol. We'll talk about each of those in some detail and review the clinical trial data that supported their approval. We'll also touch on some selected emerging factor VIII extended half-life proteins. Specifically, we'll talk about turoctocog alpha PEGol, which is another PEGylated factor VIII molecule. And then I'll very briefly mention toward the end another drug which goes by the code name at this point of BIVV001. This is another FC fusion protein which has also some interest and some very exciting preliminary data. So let's talk about these one at a time. Let's start then with F-moroctocog alpha. This is a recombinant factor VIII FC fusion protein. This is a B domain deleted recombinant factor VIII to which the FC portion of human IgG antibody protein has been linked. The pivotal clinical trial for which this drug ultimately received its approval was called the A-LONG study. This was a phase 3 study of recombinant factor VIII FC fusion protein in hemophilia A. 165 adolescent and adult patients with severe hemophilia A were studied. As you can see from the scheme shown here, those patients who had previously been treated with prophylaxis or episodic therapy were placed into arm 1, which was an individualized prophylaxis arm in which the patients were given doses that range from 25 to 65 units per kilo at infusion intervals of 3 to 5 days. There were 118 patients in that arm. Other subjects who had previously been treated with episodic therapy were randomized into another prophylactic arm, Arm 2, in which the drug was given at a higher dose on a weekly schedule, or randomized to Arm 3, which was episodic treatment, as shown here. This next slide shows some high-level results of the A-LONG study. As you can see, when compared to episodic therapy, the use of either weekly prophylaxis or individualized prophylaxis resulted in a dramatic reduction in bleeding events. The pharmacokinetic data from the study showed that the half-life of f-maroctocog alpha was about 19 hours, which is translated into about a 1.5-fold prolongation compared to standard factor VIII. Some other details from this study: we see that the majority of bleeds, 87.3%, were successfully managed with one injection of this medication. No subjects developed inhibitors, and there were no significant unexpected side effects from the medication. It was very well tolerated throughout the course of the study. Let's take a look now at the second currently available extended half-life factor VIII product. This is rureactocog alpha PEGol. This is a full-length, unmodified factor VIII to which PEG has been covalently bound. This is a 20 kilodalton PEG molecule attached to this factor VIII protein. The slide here shows some high-level pharmacokinetic data compared with standard half-life factor VIII. The half-life of this particular molecule is about 1.4 times longer. A phase 2-3 study of rureactocog alpha PEGol in severe hemophilia A was also performed. This was also a fairly large study. 138 adolescents and adults with severe hemophilia A were randomized to treatment either with episodic therapy or twice-a-week prophylaxis. When compared with episodic therapy, those individuals who received prophylaxis twice a week with this drug had a significant reduction in their overall bleeding rates. Similarly, breakthrough bleeds in this study were successfully treated for the majority of the time with only 1 or 2 infusions. No subjects receiving the drug developed factor VIII inhibitor antibodies or experienced any unexpected side effects. The adverse reactions that were seen in this study were typical. They were not significantly different than what we would expect from other factor VIII products. So the known safety profile of this drug has been well established, and the study done with the particular molecule we're discussing here showed really no unexpected side effects. Okay, let's turn now to the third currently available extended half-life factor VIII product. This is demoxicog alpha PEGol, otherwise known as BAY949027. This is a B-deleted recombinant factor VIII site-directed immunogenesis protein to which a cysteine amino acid 1804 has been introduced to allow for site-specific conjugation with a 60 kilodalton PEG molecule. This is a much bigger PEG molecule than the previous one we mentioned. Here are some high-level data regarding the pharmacokinetic properties of this particular protein. We see that, again, the half-life is prolonged about 1.4-fold compared to standard factor VIII, so very similar to the previous 2 drugs. From a phase 1 study looking at pharmacokinetic characteristics of this protein, we saw that the PK profile was comparable after a single dose and after repeated doses of the drugs. There was no change in the pharmacokinetics even after repeated doses given over time. In addition, we noticed with this drug that the PK characteristics varied a bit with age, and that's not a surprise. We know this happens with all factor VIII products. The PK characteristics in children and adolescents are a bit different than they are in adults. So again, really no unexpected findings from these data. This is a scheme of the PROTECT-8 study, which was the clinical trial done to investigate the use of this drug. The scheme is a bit more complicated here, so I'll spend just a moment to walk you through it. This was a phase 2 study which was partially randomized. There was an on-demand treatment arm consisting of 20 patients. The other patients in the study, before randomization, were given this 10-week run-in treatment where everybody was treated with a twice-a-week dose of 25 units per kilo. The purpose of that run-in treatment was to identify individuals who would be more appropriate for randomization to extended prophylaxis intervals. So at the end of 10 weeks, they looked at the number of bleeds the patients had. Those who had 0 or 1 breakthrough bleed were eligible for randomization into prophylactic arms with the drug given at every 5 or 7-day intervals at the doses shown here. Now, those arms were capped at 43 subjects per arm, so there were some patients that would have been eligible for randomization, but because the arms were already filled, they were continued on twice-a-week prophylaxis as shown here. Those are shown in the green bar on the slide. During the 10-week run-in phase, patients that had 2 or more breakthrough bleeds were not felt suitable for randomization to extended intervals, and so they were continued on twice-a-week therapy with a slightly higher dose as shown here. This is a unique feature of the PROTECT-8 study, and the goal of this was to mimic more closely what we do in our clinical practice, which is we think about the individual baseline bleeding phenotype of our patients when we're thinking about what sort of prophylactic regimen to put them on. Let's take a look now at the high-level results of the PROTECT-8 study. As we saw with the previous two studies, when compared to episodic therapy, individuals treated with prophylaxis at the regimens shown here had a significant reduction in their bleed rates. We also saw significant numbers of patients in each group achieving 0 bleeds. I would like to call your attention particularly to the every 5 and every 7 day patients who had almost a half of those patients were able to be treated without any bleeding episodes during the 26 weeks of the study itself. Similar to the previous studies, the majority of bleeds that occurred during the PROTECT-8 study were successfully managed with 1 or 2 infusions of the drug. This was well tolerated in patients, and again, no factor VIII inhibitors were seen during the course of this study. Let's take a look now at a drug that's not yet approved, but may be in the very near future. This is Taroctocog alpha PEGyl. This is another PEGylated protein. This is a bit more complicated, so this is a B-domain truncated factor VIII. It's not deleted, but rather truncated, to which a branched 40 kilodalton PEG molecule has been attached. The half-life of this drug in the first level PK studies that have been done shows it's about 1.6-fold longer than standard factor VIII, so perhaps just a bit longer than the others, but in the same general range of 1.4 to 1.6-fold prolongation of half-life. So some results from the initial clinical trials of this drug. Again, the studies are all designed very similarly. This is another study in adolescents and adults with severe hemophilia A. They have 186 patients in this study. The drug was given either on demand or on every 4-day prophylactic treatment schedule as shown here. Taking a look then at the bleeding episodes in these two groups, those receiving episodic therapy versus prophylaxis, once again, we see a significant decrease in bleed rates in patients receiving this drug prophylactically. Now, it's important to call out that one patient did develop inhibitory antibodies against this drug after 93 exposure days. But other than that, there were no significant clinical adverse events noted, and the effectiveness of this drug in terms of controlling bleeds was also very good and as expected. Lastly, I'd like to turn your attention to this molecule. This goes by a code name still, BIVV001. This is a very unique protein. This is a fusion protein to which a portion of the von Willebrand protein has been fused to a recombinant factor VIII Fc fusion protein. The purpose of this attachment of a part of the von Willebrand protein is to give additional protection and stability to the factor VIII molecule without avoiding the limitations imposed by von Willebrand factor clearance. In addition, this molecule also contains 2 X10 linkers. This is an unstructured polypeptide consisting of 6 amino acids. The fusion of these to the factor VIII protein further reduces the rate of clearance and degradation of the protein in the circulation. We don't have much data yet with this that's been published, but from some very preliminary data as shown here, we see very significant prolongation of the half-life. We see continued high factor activity levels, and so far so good with this drug. We're very excited to hear more from the coming clinical trials of this particular drug. And again, so far the safety profile looks quite good as well. Okay. So let's shift gears a bit now and talk about some key considerations for how we personalize prophylaxis in this new era of extended half-life factor VIII products. So there are a large number of factors that we need to consider when we're trying to figure out which drug and which regimen for a specific patient. Let's take a minute to just review some of the factors that we consider. So first of all, we need to think about the age of the patient. We need to think about their venous access status. Obviously, one of the advantages of an extended half-life product is the ability to potentially use fewer infusions. And so for those patients with challenging venous access, this may be an important consideration. In addition, it's also important to consider the patient's ability to adhere to the regimen. We want to be sure that our patients are able to stick to the regimen that we select for them. Ideally, this is a conversation that we have with our patients to find the best fit for each individual patient. It's important to consider all these issues. In addition, the baseline bleeding phenotype of the patient is another very important consideration. This relates largely to the patient's individual pharmacokinetic profile. We know that not every hemophilia patient bleeds the same. So we could have two individuals both with severe hemophilia. One might bleed much more readily than the other. And so we know there are important differences in the pharmacokinetic behavior of factor VIII from patient to patient. And so the peak and trough levels in a given patient and their factor half-life can be significantly different. So we have to really individualize our prophylactic strategy. Another important patient-specific consideration is their baseline joint status. Those with baseline hemophilic arthropathy may have a higher bleeding rate than those who have joints that are not yet affected by hemophilic arthropathy. So that's a really important consideration in selecting not only the drug, but the prophylactic treatment regimen. Timing of infusions is an important consideration. And the patient's activity pattern is also very important. So for patients with a more sedentary lifestyle, perhaps their prophylactic needs are going to be different for patients that have a very active lifestyle. So really it's important to consider all of these variables. This isn't simply just picking one of the drugs off the shelf and selecting one. We have to really think through this and consider a lot of variables when we're trying to figure out what the best drug for each individual patient might be. In addition to selecting the drug, we also then need to think about which specific regimen we're going to use with that drug. Okay, so let's talk for a second about monitoring the extended half-life products. If we're going to personalize prophylaxis, we need to be able to monitor our patients' factor levels. Based on studies done thus far, we know that the extended half-life factor products do have the potential to extend infusion intervals and increase trough levels, which theoretically then translates into better protection from bleeds. However, it's important to remember that each patient's individual pharmacokinetic profile can be different. And so if we're going to really personalize our prophylactic regimens, we want to be able to take these patients, test their blood, and figure out what their factor levels are so that we can understand their individual pharmacokinetics and adjust the prophylactic regimen accordingly. This becomes an issue with the extended half-life products because some of the strategies used to extend the factor VIII half-life can have an impact on our laboratory testing methods used to measure factor VIII levels. So I want to just spend a minute reviewing the two typically used assays to measure factor VIII levels in our labs. One is called the one-stage assay. This is based on the APTT test. If you're using a one-stage assay, one of the important steps in this process is to add an activator. There are a variety of activators available. Ellagic acid, kaolin, silica, and sealite are the common ones. Depending on which assay you use and which activator you use, you may get different results with some of these extended half-life factor VIII proteins that we've been reviewing today. The other factor VIII assay that's been used is the chromogenic assay. This is a different type of test which does not involve the addition of an activator. So it measures it from a different perspective, and this may have different then effects on our ability to accurately measure factor VIII levels in our patients on these drugs. This next slide shows the comparison of the one-stage assay and the chromogenic assay, taking a look at some of the advantages and limitations of each. In general, the one-stage assay is quite simple, it's rapid, it's easily automated, and has been very widely used in our country for many, many years now. However, as I mentioned already, there are a large variety of assay kits and reagents available. They differ in their activator, they differ in their phospholipid content, and they also differ in some of the other components that can be in the reagent. Because of these differences, there can be variability from testing kit to testing kit. And we also see then a high degree of interlaboratory variability with the one-stage assay. On the other hand, the chromogenic assay has a much lower interlaboratory variability. However, this is perceived to be a technically more complex and difficult test to automate. It's more expensive than the one-stage assay, and for these reasons, it's not yet widely available. So we tend to still stick to the one-stage assay, even though there may be some advantages to the chromogenic assay. That may change in the coming years, but for right now, I think most of us are still using a one-stage assay. Okay, so if we think about these two different ways of measuring factor VIII levels, and then we look at each of the individual drugs that we've already reviewed, and we look at which test performs in a certain way with each of these products, we can see some important differences. So this is a busy slide that shows a lot of data all at once, and I'll try to summarize it for you here and on the next slide as well. So you see here these four panels. Each one represents the different drugs we've talked about. With the chromogenic assay, this assay performs quite well with all of these drugs. So if that's an assay that your lab has available and you use that to measure factor VIII levels, you should get accurate results regardless of which factor VIII product the patient's on. However, if you're using a one-stage assay, we have to pay much closer attention to which specific assay is being used and which reagents are in that assay. Again, this is a lot of detail, but suffice it to say that with some of these drugs, some of these reagent kits, and some of the different activators can have an impact on the factor VIII level. We may have problems with reporting lower than actual levels or higher than actual levels depending on which assay we use with which reagent with patients on these varying drugs. So let's take a look at this in a more simplified form. So the potential consequences then of using assays that may not accurately measure factor VIII levels in our patients on these extended half-life proteins, the consequences can be significant. So on one hand, we might underestimate factor VIII levels. This could lead to unnecessary additional dosing. If we think the levels aren't as high as they actually are, we might increase the dose. This can lead then to higher chronic dosing, which increase costs over time. In addition, if we're underestimating factor VIII levels, it makes it more difficult for us to reliably know whether a factor VIII inhibitor has developed. This issue of underestimation of factor VIII levels with the one-stage assay is most notably observed with the silica-based PTT reagents in the use of the drug democtacoag alpha PEGyl. So if your patient is on that drug, you need to know whether or not your lab is using an assay with these particular reagents. On the flip side, we can also have problems with overestimation of factor VIII levels. So if that's the case, then we may result in ineffective hemostasis because we might be using doses that aren't as high as they need to be to protect the patients. The factor VIII level we get back is higher than it actually is in the patient, and this might lead then to an increased risk of breakthrough bleeds. This is a particular issue when ellagic acid type PTT reagents are used with rureactacoag alpha PEGyl rather than silica or kaolin based reagents. So again, the bottom line here is it's really important to know which drug your patient is on and more importantly, which assay your lab is using if you're using the one-stage assay. We want to be sure that when we're measuring these factor levels, we know that the results are reliable. Okay, so turning now again to this high-level conversation about how do we select which extended half-life product to use in a given patient? How do we pick between an extended half-life factor VIII product or a standard half-life factor VIII product? Again, I've mentioned some of this already, but the key thing here is there's a lot of variables that we have to consider. Venous access is important. Ideally, if we're going to use an extended half-life product, we would expect that product to provide a lower bleeding rate and improved adherence over time. The selection of the optimal drug and the optimal regimen is based largely on the patient's individual pharmacokinetic profile. In order to do that, we have to be able to accurately measure levels, and we spent some time talking about some of the issues to be considering there. In addition, I think it's very important to think about this conversation with our patients as being a balance between our goals and what the patient's goals may be. We may have a set of goals that are a bit different from what the patient has, and so it's important to have that conversation in a collaborative way, making sure that the treatment regimen we select is a mutual decision between the treater team and the patient himself. Cost considerations are also important. When you look unit for unit, the extended half-life products tend to be a bit more expensive, but we can't look at it just at that level. We have to think about consuming factor over a long period of time. Although it might be more expensive unit for unit, if you're doing fewer infusions, the cost ideally would be neutral or perhaps only slightly higher, but if you get improved hemostasis, if you get improved bleed protection, that could be a fair trade-off. So the cost consideration is a very complicated discussion that's hard to sort of talk about globally, but it's important to just call out that cost is one of the things that we have to consider, as well as all these other factors that we've been discussing. In addition, we haven't talked much yet about how these different extended half-life factors might compare with each other. Well, the reason for that is we don't really have any head-to-head comparison yet. We have a lot of data that's come onto the scene now in the last several years explaining how these factors work and showing that they're very effective when used prophylactically, but we don't really have any direct head-to-head comparisons. As I showed you earlier in today's program, we saw that the half-life prolongation is very similar across these different products, but if you look carefully at how those studies were done, they weren't designed exactly the same. So the treatment regimens that were studied and those then that got approved are not exactly the same. And so it can be difficult for us to think about which drug to use with which patient because the treatment strategies are not exactly the same. The approved dosing intervals are different. So I think in the future it would be ideal if we had some head-to-head comparisons. Whether that will happen or not, I think time will tell. But right now it's difficult for us to make that decision based on data. We have to think about this more based on what our real-world experience has been. And so I would just say stay tuned over the next few years, I think we're going to see more and more real-world data, and it may be at some point down the road we'll be able to sort of say, this drug performs this way versus that drug. Right now, we just have the information from the initial clinical trials and what's out there. We finally have these drugs in our hands, so now we're entering this phase where we actually will generate some real-world data and some experience that might help guide our decision-making down the road. Okay, so with all that being said, let's kind of wrap this up and move on to some questions and answers. So we've talked a lot today about a lot of different things. We've talked about the extended half-life proteins that are currently available. We've talked about the basic data from the clinical studies that have led to these drugs being approved. I've touched on some emerging therapies, and there are others that we didn't talk about today just because of time constraints. We also talked about the importance of personalizing our prophylaxis. We talked about many of the variables that are important in considering which drug and which regimen for which patient. It's hoped that the modification of these factors, as we've described, that prolong the half-life, will offer more convenient and more effective therapy for our patients. However, again, the important point is that we have to personalize this. In addition, we just spent some time talking about some concerns and some issues around laboratory monitoring. If we're going to really personalize prophylaxis, we have to be able to measure factor levels accurately so that we can investigate each patient's pharmacokinetic profile and make the appropriate dose adjustments to really fine-tune that regimen for each patient. When selecting an extended half-life factor VIII, it's important to know which assay your lab is using and to know how the different drugs that your patients are being treated with may be affected by the use of those assays. And we've reviewed that in some detail. So this is a new variable that we have to consider, but it's a very important variable if we're going to be able to accurately measure factor levels and translate that into pharmacokinetic testing to really understand how to personalize our prophylactic regimen for our patients. With that, we come to the end of my part of the presentation. I'd like to turn it over now for some questions and answers. Okay, so here's the first question that's come in. The question is, what is our experience with extended half-life factor VIIIs in clinical practice? Have we utilized all that are currently available? So in our center here in Minneapolis, yes, we are using all of the currently available products. There's one that just got approved very recently, so we haven't had a lot of experience with it yet. But we are currently using all of the available drugs. Patient preference plays a big role in which drug we select. What we like to do with our patients is we like to sort of sit down and go through all the available options, talk about the different features of the different drugs, and have a conversation with the patient. Sometimes our patients have very strong feelings about which particular product they'd like to be on, and we obviously have to factor that in to the discussion as well as all the other variables that we reviewed earlier in today's program. So it's a very good question, and the short answer is, yep, we're using all of them, and I think over time we'll continue to use all of them. Right now I don't think there's any way to say that there's one preferred versus the other. I think all of these are really good choices for our patients. Okay, here's a good question. So the question is with the results of the SIPPET study, how concerned should we be about patients developing inhibitors with extended half-life products? This is a great question. This touches on some really, really important and potentially controversial issues in hemophilia. So a couple of points here. So the SIPPET study did not include patients treated with extended half-life products. We don't have any direct way to know from that particular study whether the extended half-life products have a different rate of inhibitor formation compared to the standard half-life products that have been available. As I showed you with the clinical trial data we reviewed, we've seen a very good safety profile, but it's very important to point out that the published data to date includes patients that have been previously treated. We don't have a lot of PUP data yet. And so I think right now it's too early for us to say what the real rate of inhibitor formation will be with these different extended half-life factor VIII products. So it's a very, very good question, and I think right now the jury's still out on that. What I would like to say is just more to come on that. So we'll be eagerly awaiting further data and further real-world experience to know whether or not there's a difference in inhibitor formation with the extended half-life products. Okay, another question that's come in. Aside from inhibitor patients, are there any patients with hemophilia A that you would consider using an extended half-life factor VIII for prophylaxis? So if I understand the question correctly, I think what it's asking is, for whom do we consider an extended half-life factor VIII product? And the answer is really everybody should be considered. we don't always make the decision to switch a patient to an extended half-life product, but I really think any patient is potentially eligible. This is a conversation that goes beyond just which drug do you use. I think the conversation really focuses on which regimen do we really want to use to give this individual patient the best bleed protection. And sometimes in the course of that conversation, we come to the point where recognizing that an extended half-life factor VIII protein may offer some advantages that would help the patient either be more adherent or get better protection from bleeds. And so, again, really any patient is potentially eligible for consideration of using an extended half-life factor VIII product. There's one more that just came in. Have patients developed inhibitors to any of the approved EHL factor VIII in the real-world setting? I don't have specific data to share with you, but I can say the answer to that is yes. I am aware of some case reports of individuals developing inhibitors on extended half-life factor VIII products. We don't have yet published data that really can speak to the incidence of that, but the answer is yes, that we have seen that happening. So I think, again, more to come on this. Stay tuned. As we use these products more and more and expand their use into previously untreated patients, we may have a better insight as to what that number really is. The question is Demoxicog alpha now available to prescribe? Short answer is yes. That is the most recently approved PEGylated recombinant extended half-life factor VIII product. It is now available. So here's another one. Do you adjust dose interval in all of your patients treated with extended half-life factor VIII? It's a complicated question, but I think the basic answer there is yes. The whole goal of using an extended half-life factor VIII product is to allow for an extended dosing interval. I mentioned in one of the earlier slides that another potential use of the extended half-life product is to allow for higher trough levels, but I think when we really look at these products in our clinical practice, we're really looking to extend the dosing interval. It's important to point out that not every patient is going to be able to do that, particularly in younger patients where we know the pharmacokinetics are different. Not every patient is a good candidate for an extended half-life product. Kind of referring back to one of the previous questions, though, every patient is potentially eligible, and so I think we should consider these products for all patients, but after we go through the analysis of the individual features for that patient, we may come to the place where we don't feel that it's a good fit for each specific patient. So we do adjust the interval. Our goal of using these products in our center is to achieve a longer interval between infusions. And so, is your pharmacokinetic profile going to be drastically different if we switch from a standard half-life factor VIII product to an extended half-life factor VIII product? The answer is basically yes and no. What do I mean by that? So we know that if we use an extended half-life product, we're going to see prolongation of the half-life. That should happen in everybody, but not everybody's half-life will be prolonged sufficiently to allow them to take advantage of extended dosing intervals. In other words, there are some people who have pharmacokinetics that are just such that an extended half-life product really doesn't offer them the ability to extend the interval longer. And so they're not a good fit for every single patient. Said differently, not all patients have a pharmacokinetic profile that allows them to take advantage of the main benefit of an extended half-life product, which is an extended dosing interval. On the other hand, I'll say that we do see patients that have really good pharmacokinetics, even with standard half-life products. Some of those patients are the ones that are able to get the most extension of the dosing interval with an extended half-life product. So I think in summary, to answer this question, if you have a very short half-life with a standard product, you're going to have a shorter half-life than average with an extended half-life product. If you have a longer than average half-life with a standard product, we'd expect you to have a better than average half-life with an extended product as well. So thanks again for your participation in today's program.
Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/WVM. This activity is supported by an educational grant from Bayer Healthcare Pharmaceuticals Incorporated. This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education.